have to change the position.
Yes.
Okay.
So, good evening, everyone. Today's lecture is on infective endocarditis by Dr. Niroshan Lokunarangoda. He's a graduate of the Colombo Medical Faculty and was a trainee in registrar in medicine at the NHSL attached to the professorial medical unit. He won the Dr. Nanda Amarasekara Award for the best performance in the MD medicine examination held in 2011. He had his initial cardiology training at the Institute of Cardiology NHSL and had his overseas training at the Shrewsbury and Telford NHS Trust and Royal Stoke University Hospital, UK. He was board certified as a consultant cardiologist in 2015 and was attached to the Rajarata University Department of Medicine initially, and he was the head of the department there, but later moved to Moratuwa, University of Moratuwa, and now he is the head of the Department of Medicine there. He has a lot of research interests and has published more than 20 articles in peer-reviewed. He's also a program director for various training programs, and he is into teaching and training postgraduate trainees as well. So over to you, Dr. Naroshan.
Right. Good evening, everybody. Thank you, sir, for the introduction. So, for next hour or so, we will have a look on some aspects of infective endocarditis, which will be useful in our day-to-day practice. So, infective endocarditis. So, right. Can you see the moving slides? Slides are moving.
Yes.
Is it? Yes. Okay. So here we are going to discuss a bit about epidemiology, clinical manifestations, and diagnostic criteria, because last year it was updated uh, from ESC as well as from the criteria itself, and then management and few specific special situations and prevention. So for this presentation, I incorporated a lot of guidelines, but basically the last updated guideline is last year 2023 ESC guidelines for management of endocarditis, and also few months later, the same year, Duke criteria also updated. So many of these, some of these uh, ESC guidelines have not included this modified Duke criteria. So I'm going to discuss it. These are not much change, but there are few changes. So infective endocarditis. It is an endovascular infection of cardiovascular structures, including cardiac valves, atria, atrial and ventricular endocardium, large intrathoracic vessels, and intracardiac foreign bodies. So it is an infection, it's an endovascular infection. So it is due to inflammation of endocardial surface due to bacterial or fungal infection, and it causes vegetation. These vegetations typically form on heart valves, but it may be elsewhere as well. Having said that, there is something called non-bacterial thrombotic endocarditis. You must have heard this. It's a rare condition. There you have tiny sterile endocardial lesions composed of platelets and fibrin, which are associated with malignancy and connective tissue disorders. So, only few slides on pathogenesis. So, many of these infective endocarditis patient has underlying valve abnormality. There is a turbulent blood flow and jet effect. So, which causes transient bacteremia, which lead to colonization over this underlying valve abnormality, and infection sets in. But normal valves also can get this infection and vegetations due to virulent organisms like Staph aureus, as in intravenous drug users. So bacterial entry can be with your mouth, or your gingival cavity, or whatever place, or GI tract, or skin or through intravenous lines. So whatever, there is a breach of the endothelium, and then this bacteria will go in and there's a proliferation, bacterial proliferation and neutrophil and macrophage infiltration, and finally there's a vegetation formation. So I'm just want to simplify because we want to go for more clinical details rather than going in pathology. So if you go for the epidemiology, worldwide there's a male preponderance. However, female proportion increases with age. Nobody knows what is the real reason for male preponderance. Some people think it's a maybe slightly higher risk, higher incidence of congenital abnormalities like bicuspid aortic valve like things. But there's a male preponderance. In high income countries, it is mostly due to staphylococci. It may be related to degenerative valvulopathies and having more prosthetic valves and implanted devices. But in low income countries, it is mostly streptococci and it's associated with rheumatic heart disease. In Sri Lanka also, we have almost similar pattern. It's a mostly streptococci. So infective endocarditis can be classified by various ways. You can classify it according to the etiology. It may be bacterial, fungal. You can classify according to that. Or by organism itself, streptococci, staphylococci likewise. Or disease cause, acute. Usually less than 30 days, you say acute endocarditis. Or subacute or chronic endocarditis if it is more than 30 days after onset of symptoms. And depending on the valvular involvement, if it is happening to native valve endocarditis, which is the commoner type, uh, so it is native valve endocarditis, and then it could be prosthetic valve endocarditis, which has worse prognosis, and also you can classify it as side affected, right-sided endocarditis and left-sided endocarditis. Left-sided endocarditis has less favorable prognosis. So in 2015 and even last year update of ESC, they consider endocarditis should be managed as a team. The core members include cardiologists, cardiac imaging experts, cardiac surgeons, infectious disease specialists like microbiologists, and specialists in outpatient parenteral antibiotic treatment, and then adjunct specialists, radiologists, pharmacologists, neurosurgeons, nephrologists, anesthesiologists, critical care specialists likewise. So it's a teamwork, as many of the other like heart failure management team likewise. Nowadays, in the current context, it is considered as a endocarditis team. So what are the risk factors which uh, increase the risk of infective endocarditis? There are cardiac risk factors as well as non-cardiac risk factors. So highest risk factor is previous infective endocarditis. It's a cardiac risk factor. And also pre-existing valvular heart disease. Depending on the valve affected, it is different, but having valvular heart disease itself is a risk factor. Prosthetic heart valve, having central venous or arterial catheter, or transvenous cardiac implantable electronic device, or some of the congenital heart disease definitely have high risk of having infective endocarditis. So as you are aware, having central venous catheter and people who inject drugs, this is the new term for IVD. We used to tell intravenous drug users, but now a new term is PWID, people who inject drugs. So it is one of the risk factor, and having immunosuppression and recent dental or surgical procedures, recent hospitalization, and hemodialysis itself is a risk factor. So then how do we diagnose infective endocarditis? Clinical, echocardiographic, and other criteria. So presentation depends on several things. One thing is virulence of the organism and persistence of their bacteremia. So depending on them, there will be extent of local tissue destruction of the involved valve. And because of that involvement, there will be hemodynamics sequelae, and the presentation will differ depending on those. If there are any perivalvular extension of infection, also there will be different clinical features. And then septic embolization to any organ or to the systemic circulation or to the lung, as in right-sided endocarditis, will give different clinical picture. We'll discuss this system by system in a brief manner. And finally, there is a immunocomplex formation, and some of the clinical features are due to circulating immune complex deposition. So, as you are aware, the commonest, or maybe one of the commonest presentation is with fever. So 95% up to 95% of patients will present with fever. But many presents with non-specific constitutional symptoms such as chills, sweats, cough, headache, malaise, nausea, myalgias, and arthralgias. Heart murmurs are found up to 85%. You can have other skin manifestations like petechiae on skin, conjunctiva, or oral mucosa. Splenomegaly may be 10 to maybe around less than 30%. Up to 25% have embolic phenomenon at the time of diagnosis, but these embolic and immunocomplex phenomena are now becoming less because of the early antibiotic treatment of the many of the things. So just to show the percentage of the Western series, you can see fever is a presentation for many of the patients, and fever with chills still at least 50% or up to 70%. A lot of non-specific symptoms are there. You can see lymphadenopathy is not a feature in this condition unless etiologically associated. So again, just to show some clinical features for you, heart murmur is present again in majority of the patient, and some patients have new onset murmur or change in murmur. When we come into the minor criteria, we can discuss all these things again. So the typical peripheral stigmata of infective endocarditis we have been talking about since medical student days are very rare, like sphincter hemorrhages, chain vein lesions, osler nodes, Roth spots. You can see it is around 10%. So although we say always these are very rare, many of the instances. So this chart or this diagram show all the possible complications and involvement with the clinical manifestation. So heart, it can cause vegetations which lead to hemodynamic effect and embolization, because valve mainly regurgitation, acute regurgitation can cause severe heart failure, It can cause myocardial abscesses, periannular extension of infection can cause fistula and shunt, myopericarditis. And vascular complication is myocardic aneurysms, which can rupture, and renal manifestation we'll also discuss again. So likewise, you can classify the presentation. So if I tell few words about individual complications quickly, this cardiac, the vegetations, the cardiac manifestation commonly as vegetations, usually located along the line of closure of valve leaflet. It is on the atrial surface of the AV valves or on the ventricular surface of the semilunar valves. That is very important when we are doing the echo. Sometimes DD is coming this way. But usually acute endocarditis rather than subacute endocarditis, the vegetations are larger and more friable. And some have myocardial abscesses up to 20% of patients. Embolic phenomena are common and they frequently involve cerebral, renal, splenic, and coronary circulation. So I just want to show because of this echocardiography is one of the main diagnostic criteria, because I just put this slide into just to show that it is useful in the diagnosis of endocarditis. It's a first line, you have to do the transthoracic echo, TOE, to assess the severity of the disease. It is to the diagnosis and the assess the severity of disease, and it will give some idea about the short term and long term prognosis. For example, if it's a larger vegetation, if there are any associated complication, the prediction of prognosis is also can be given through the echocardiography. And prediction of embolic risk, larger fragile looking vegetations, you might have a clue. And also it is helping for the management of complications of the endocarditis, and later follow up in the course of treatment. Where do we need TOE? I'll skip this slide and we can come in there. Right, yes. So, because as the doctors who are working in the cardiology units, you should know where we should do the echo. Yes, all the patients should need transthoracic echo. But now these guidelines more emphasize on TOE. They say all the patients with clinical suspicions of infective endocarditis are negative or non-diagnostic TTE. They always recommend, in addition to transthoracic echo, most of the patient better to have TOE according to this guideline. Especially, it is very important if you have a negative or non-diagnostic TTE. That means you have a patient you clinically suspect in infective endocarditis as your differential diagnosis, but your transthoracic echo is normal. So definitely you should go for a TOE. And also your clinically suspect endocarditis in prosthetic heart valve or intracardiac device, you have to have a TOE. Oh, if initially negative transthoracic echo, again you might repeat this after 5 to 7 days if you feel it is still clinically suspicious. So when we are following up, because I'm just emphasizing this echo part only, because I'm not going to much detail on the other lot of investigations, because echo and TOE you may be using very much as your day-to-day practice. So you have to repeat transthoracic echo or TOE if you suspect new complication. That is one of the indication. If you suspect having a new complication like new murmur or any evidence of embolism or persistent fever or bacteremia or evidence of clinical heart failure, if you suspect some complication, definitely you have to repeat the transthoracic echo. And again, this new guidelines are suggested because this uh, evolution of management, now they identified you don't need to treat 4 weeks of IV antibiotics in some of the patients. We'll come into that point. If you are planning to change intravenous antibiotic to oral antibiotic in that selected patient, one of the important thing is you have to do a TOE at the day 10 or maybe day 14 to take that decision. That is the one of the important thing. It's a class 1 level B indication. Without TOE, ideally you should not do, you should not have that decision. So we are doing echo at the end of the completion of antibiotic therapy, you know that. So this is the summary thing. I think this is enough to remember. So you anyway clinical suspicion of infective endocarditis, you do transthoracic echo. If it is non-diagnostic, if it is positive, even it is negative, if it is prosthetic valve or intracardiac device, TO is recommended. If negative TTE, if the clinical suspicion is high, you should do, but if it is low, you stop and you think of other diagnosis. But initial TOE is even negative, but if your clinical suspicion is remaining high, you should repeat your transthoracic echo and or your TOE within the next 5 to 7 days. I think this slide summarizes most of the things. I think you can remember this one. That is enough. So what are the echocardiographic features? Just to know, I think many of you have involved in echo. Many of you are doing that as well. You are working in cardiology units. So you are familiar with the appearance. Vegetation is an infected mass attached to an endocardial structure implanted intracardiac material. You can see different vegetation in the different valves. Is a mitral valve endocarditis. This is a tricuspid valve endocarditis. Mobile oscillating mass, but it is not necessarily to be oscillating always. There may be non-oscillating vegetations as well. There may be flat vegetations less commonly. So it is very difficult sometimes by appearance to get this. Again another vegetation. Yeah. You can see the tricuspid valve annulus. There's a big vegetation uh, moving through the valve. This is the vegetation from the pacemaker lead from the right-sided endocarditis at the tricuspid valve. Which is at the right atrium. So the other feature is abscess. You can have a abscess. You can have pseudoaneurysms, because I have to quickly go through because there are lot more to things. There are definitions and you can read with the guideline. There may be perforations. There may be abnormal communication between two cavities, that is called fistulae. You can see is the left atrium and left ventricle. There will be a destruction of the valve of this mitral valve. and there's a fistula creation. You can see this glowing part. So that's a fistula. So the other complication is valve aneurysms. These are the echocardiographic features and complications. And then the dehiscence of the prosthetic valve. So it is a very dreaded complication with some moments. But not always these are easy. So sometimes mitral or sometimes valvular calcification or fibrosis might mimic vegetations. And in the mitral valve myxomatous degeneration, very difficult to identify whether it's a vegetation or not. And sometimes our angle of echocardiography might give some different and difficult views, and some strands and some old vegetations you can't diagnose whether it's a new vegetation or active vegetation. Then you have to go by other parameters, clinical parameters and uh, lab parameters. And sometimes tumors, cardiac tumors like fibroelastomas and all. I think this one is a fibroid, yeah, can mimic vegetations. So quickly go through the organ system involvement. Kidney endocarditis can affect the kidney in three ways. One is septic emboli, then infarction and glomerulonephritis. So if you do the urine full report in this patient, they can have uh, microscopic hematuria and maybe red cell cast. It is a immunocomplex glomerulonephritis. So you can see some infarcted areas of this gross specimen of the kidney. So the vascular involvement, they can have mycotic aneurysms. That is because it causes aneurysmal dilatation of the artery. Basically, they think three ways. It may be due to direct invasion of the arterial wall, or maybe embolic occlusion, no immunocomplex deposition. Whatever the way, the vessel wall is damaged and thinned, and there will be aneurysmal dilatation. So they can happen at anywhere, but the most dreaded place is cerebral circulation. You can see mycotic aneurysm in the one of the cerebral vessels. So how this involving the nervous system? Cerebral emboli are the most common serious complication, and this emboli can shoot into the middle cerebral artery, and cerebral infarction and arteritis, and a lot of complication can happen. And Roth spots are the retinal manifestation of infective endocarditis. So as medical students is one of the famous OSCE, and you should know. But Roth spot is not pathognomonic of infective endocarditis. It can happen with other conditions like vasculitis, SLEs, and other many of the conditions. But it can also happen in infective endocarditis. And remember, if patient get emboli from infected endocarditis, you can't thrombolize. It is a contraindication, right? If you are suspecting infected endocarditis and if you get acute stroke, you can't thrombolize with alteplase or whatever tenecteplase, because pathology is totally different. It is due to something else. It will not affect your septic emboli. Right. Splenomegaly is common, and infarct also common and usually clinically silent. But when they get splenic abscess, you rarely you will find one or the other day in your CCU, the patient present with fever and left upper quadrant pain and leukocytosis due to splenic abscess. They may present to the surgical ward as well. Lung lung is affected usually with the right-sided endocarditis due to pulmonary embolism with or without infarction. It can cause acute pneumonia and effusions and empyema. So skin involvement or mucous membrane involvement is due to septic emboli or immunocomplex deposition. You can have petechiae. You might see the petechiae in several places, but if it is dark skin, you might miss. You have to check this. Palatal petechiae you can see here, and conjunctival petechiae. So typical Osler's nodes are painful. Erythematous nodular lesion located in the pads of fingers and toes due to immune complex. Immune complex ones are usually painful, and it's partly be due to focal vasculitis. Genial lesions are painless hemorrhagic macules uh, at soles or palms due to peripheral septic embolization. These are less common. I told it was around 10% of the patients. Splinter hemorrhages are also painless, dark red linear lesion in the proximal nail bed and maculae. It is also due to septic embolization. Again, splinter hemorrhages also can happen with other conditions. Even trauma can cause splinter hemorrhages. So, what are the organisms which cause infective endocarditis? So, there are typical organisms because the microbiology point of view, these are important because the diagnostic criteria are slightly different with these typical organisms and less common organisms. Because definitely we have to involve microbiologists for this management as the endocarditis team. So all the streptococci except pneumonia and pyogens and streptococcal uh, lugdunensis as in PWID and Enterococcus faecalis and other types including Hackett group are considered typical organisms. Why it is important? If these were isolated, even two blood cultures are enough for diagnosis as a major criteria in the diagnosis. In the setting of prosthetic valve endocarditis, you have separate, slightly different set including staphylococci. And staphylococci, corynebacterium, serratia, pseudomonas, utibacterium, and some non-tuberculous mycobacteria. Many of them are either skin commensals. So you have to improve their skin hygiene as well. So very basic slide from medical student days also. Infective endocarditis organisms. We learned this from medical student days. If you get into this region, native valve endocarditis, 70% is due to streptococci. So subacute bacterial endocarditis mainly due to streptococcus viridans. Uh, People with intravenous drug use, IVDAs, Staph aureus is the main culprit. If the patients are with bowel malignancy, main culprit is likely to be Streptococcus galileoticus. We used to call it Streptococcus bovis earlier. And GU disease, genital disease. So if it is associated with genital procedures, you have to look for Enterococcus faecalis. Prosthetic endocarditis, it could be late or early. Different book says different time for this definition. In this guideline, it says less than 6 months is early and more than 6 months is late. Basically, early means these valves are inoculated or infected during the perioperative period most of the time within first 2 months actually, and this has poor prognosis and the organisms are likely to be staphylococci, staph epidermidis or aureus. So we have to aggressively treat because prognosis is very poor. The late ones, they usually presents after 1 year actually, not 6 months, even it's 1 year. They are usually with our common flora like Streptococcus viridans, but still they can have Staph aureus. So fungi as a cause of infective endocarditis is usually associated with previous hospitalization, parenteral nutrition and antibiotics, injection drug use or immunosuppression. So you can have fungal endocarditis due to some other reasons. hospitalization, parental nutrition or previous antibiotic use or drug use, or patient is already immunosuppressed, where you can find Candida or Aspergillus commonly. But there is something called culture negative infective endocarditis, CNI. What is the main reason? Main reason is prior antibiotic therapy. But there are some other reasons, like some organisms you can't get cultures at once because they need special techniques and it takes some time. So initially you think it is culture negative. So nutritionally variant streptococci, you need special cultures. Intracellular bacteria or fastidious organisms like Hackett group or other non-infectious causes. So according to the Duke's or modified Duke's criteria, our patient who comes with symptoms, signs, you can categorize them into three. You can categorize into three ways: definite in IE, possible IE, rejected IE. That means no IE. Definite IE needs two major criteria, or one major, three minor, and or five minor criteria. So we'll go one by. So the Duke's criteria has been modified earlier as well, but I told you after this ESC guideline came, this same year Duke criteria again modified. The major modification is they included pathologic criteria for the as a major criteria. Basically, the previous slides they just consider the clinical criteria, clinical and yes, clinical and other excluding other pathological criteria. But now, according to this Duke International Society of Cardiovascular Infectious Disease, it latest modified Duke's criteria 2023. Now they included pathologic criteria as well. That means if pathologists found this evidence of vegetation or evidence of active endocarditis, still it is a endocarditis. So I told you that was a definite infective endocarditis. Possible infective endocarditis is one major criterion and one minor criterion or three minor criteria. Rejected endocarditis, that is very important again. When you have firm alternative diagnosis, say you have some other diagnosis like typhoid fever, whatever, and or maybe lymphoma, then you have firm diagnosis, you can reject. Or resolution of syndrome by less than or within 4 days. That means you initially thought of infective endocarditis and you started empirical treatment with some basis. And with that particular antibiotic treatment, within 4 days, all the symptoms have gone, and even some clinical parameters have almost gone. So it is very unlikely it is infective endocarditis because infective endocarditis will not go away within 4 days. So it is a very unlikely. It should be other reason. Right. So microbiology criteria, that is also one of the major criteria. This is very important for you because positive blood culture is the one of the major criteria. So you should know how to take blood cultures properly. So we are learning because day by day these things are changing as well. So as usual, the blood culture is the remain the gold standard. But ideally, you have to take the aerobic cultures and aerobic cultures. That's why all sets of blood cultures. Set means aerobic and anaerobic. But in Sri Lanka, we don't have anaerobic cultures most of the time. We have only aerobic cultures. So to get the typical idea, if you get typical microorganisms, two blood cultures may be enough, but you have to ideally take three cultures. But non-typical or other microorganisms become positive, definitely you have to show they are positive in at least three blood cultures. So you should know how to clean the area and how to uh, do the technique. So cleaning, you can do the alcoholic chlorhexidine, or maybe if it is not available, 70% alcohol followed by povidone iodine, as you have learned from your medical student days. You have to take three cultures as mentioned earlier. Those days, there are strict rules that you should take different places, but according to this guideline, 2023 guideline says, if it is difficult to take blood from the different places peripherally, at it's good enough to get same place in a different times, not the same time. Say if it is a right antecubital fossa, if it is the only place available, get it, but not in the same time. Also, specific time is not also not specified in this criteria. They say because infective endocarditis is a condition which we have persistent bacteremia. So it's true, you can make it wider apart. Earlier, we were told take it at least half an hour apart. But this guideline does not emphasize that. Ideally, you can take it apart, but if you don't have time or patient is too ill to start your antibiotics, you can get blood cultures quickly in several places, but um, if it is not possible, when even in the same place. So it is obtained from the peripheral vein rather than from a central vein, right? So 10 milliliters of blood is needed for adult, but children, you have, it is depending on the uh, particular bottle. You have to check with the bottle. It may be 1 to 5 milliliter according to the ratio of the blood you have to give. Keep the room temperature. If you are unable to send it promptly, you should not refrigerate. If you want to get fungal culture, you have to discuss with your microbiologist and microbiology lab and get the specific bottles. So there are some other additional tests that consider major criteria which are not available in our country, but guidelines say several criteria. I'm just skipping the slide. So other major criteria including echocardiography and CT findings. CT. So if I summarize this slide, this 2015 and 2023, they identified, rather than conventional echo, you can have cardiac CT to the help to identify this vegetation and all these valvular lesions. Complications I have mentioned for the echo. And also they identified positron emission CT with FDG PET scans, also helpful because when you have some infectious foci, there will be abnormal metabolic activity, especially when you have a prosthetic valve or maybe some other place. So in the as aortic graft or any other place, it may be very useful to have some scan to show some infective activity. So you can take as a major criteria according to these guidelines. So some of these things are not happen in this country, but cardiac CT we are doing. We use this for infected carditis as well now, rarely. Surgical major criteria, if you find the things during the surgery, you can take as a major criteria. So minor criteria, there are several minor criteria. I'm quickly going through. Now, previous history of infective endocarditis itself, according to this guideline, considered as a minor criteria because this is the biggest risk factor. That is why. And if you have fever, if you have vascular phenomenon, if you have immunological phenomenon, any other microbiologic evidence, and imaging criteria, you can go through in the guideline. And also they added the physical examination. So if you find a new murmur, you can consider it as a minor criteria as well. Not the worsening of murmur, but a new murmur. But it is fairly subjective, but they added. So some images, you can see metabolically active areas with the PET CT scan because these have some infection. I'm not going to discuss about the technical details on this. That is the edge of the prosthetic valve. There is some abscess formation. That's why it has some big collection of enhancement. So this is the same thing I have told, so I can skip. So you can see the vegetations of the and also root abscess actually. It's a root abscess, aortic root abscess from the CT scans, cardiac CT. So you can see the complication of the cardiac CT very well. So these are major criteria. So here also you can see the third middle slide. There is an aortic root abscess. This is also from the cardiac CT. So we had only blood cultures, 2D echo and transesophageal echo, transthoracic echo and transesophageal echo. Now we have cardiac CTs and other lot of scans and lot of serological investigations, but may not be available in our country. So this is a myocardic aneurysm I have shown earlier. So this is the summary of what I have already told. So if you suspect native valve endocarditis, you have to do with baseline initial assessment, and then you have to try for to put this diagnostic criteria and get whether it's definitive, possible, or rejected. So there's an algorithm I'm not going to go through, but you can go through this. So if I go move into the management of infected endocarditis, in addition to that particular previously mentioned diagnosis investigations, we have to go with the supportive investigations. Full blood count, there may be neutrophil leukocytosis and mild nomochromic nomocytic anemia, and ESR and CRP will be high. Procalcitonin will be high with infection. Blood picture might show again anemia with some neutrophil left shift. Rheumatoid factor can be positive. Troponin can be positive in the case of severe infective endocarditis. BNP can be high in the evidence of when if there's a presence of heart failure with acute regurgitation and all. UFR may be positive for red cells if there's immunocomplex glomerulonephritis. Creatinine may be high when you have uh, acute kidney injury due to disease process itself or your drug treatment such as aminoglycosides. ECG will show different things, including the cardiac heart blocks, because some of the organisms can cause valve abscesses and congenital complete heart blocks. Chest radiograph might show some evidence of the heart failure. If it is right-sided endocarditis, maybe some pulmonary involvement. So, as I mentioned earlier, colonoscopy, if you are thinking of colorectal disease or neoplasms, in the case of Enterococcus faecalis or Streptococcus galileolyticus endocarditis, if you are suspecting brain MRI, intracranial complication, you have to give the brain MRI and serological or molecular testing for unusual pathogens. You can get histological examination if cardiac surgery is done, but we usually don't do the routine culturing of the excised material. You can do the cardiac CT if you are thinking of paravalvular infection or other echocardiography is not doing your job well. So now this is the very important part again, because there are some new things you should learn, because when we learn from medical school, these have been changed now with new guidelines. So we were told, so it's a severe infection, you need prolonged intravenous antibiotics. Yes, it remains true. Many of the complicated infective endocarditis needs prolonged antibiotic treatment, 4 weeks or 6 weeks or even more, depending on the complications and the conditions. But there are some exceptions according to this. So when you get a patient, there are two phases: early critical phase and continuation phase. So early critical phase, you have to treat rapidly. IV rapid bactericidal combination, and if there are indications, cardiac surgery, we'll discuss that. And if there are infected cardiac device, you might have to remove that. And if there are any pus collections, we have to drain it. So that is the early critical phase. But if the patient is improving, especially without having any complication, if there's a very smooth recovery, especially in some organisms like Streptococcus viridans, left-sided endocarditis, so you can think of some oral treatment. So it is a continuation phase. In continuation phase, complicated phase, definitely need intravenous inpatient treatment, as we have been doing. But uncomplicated cases, if you have identified the organism and they are not that virulent, and if you have available oral antibiotic for that particular organism is sensitive, you can try with oral antibiotic. Or if it's oral antibiotic therapy is not good, you can have oral outpatient parenteral treatment, OPAT. But to take a decision, additionally, as I mentioned earlier, you have to do the TOE before the before you switch therapy. So our successful treatment relies on microbial eradication. So it is identified that there is a bacterial tolerance, not resistant, because some of these bugs are escape in the drug-induced killing and may resume growth after treatment discontinuation. Therefore, that's why we give sometimes combination of bactericidal antibiotics. That's like something like ceftriaxone plus gentamicin. That's why giving combination to reduce this tolerance. In the prosthetic valve, definitely you have to treat with 6 weeks prosthetic valve endocarditis. And next point is very important. If you have positive blood culture, or maybe you don't know it's positive blood culture, it's a good practice to have 48 hours or 72 hours another blood culture. as a clearance blood culture, because in microbiology they have something called first day of effective antibiotic therapy, because they calculate according to this guideline the day number, not the starting of the antibiotic days. Really speaking, they think the first day is first negative blood culture. So in other words, if you start treatment, first before treatment you have to take 3 sets of blood cultures, and then once you start treatment empirically or whatever target, you have to get another blood culture, at least one blood culture, after 48 hours to 72 hours, because if it is negative only you can consider that is your treatment has started positively. Few words about aminoglycosides, that is gentamicin and other aminoglycosides. They synergize with cell wall inhibitors, beta lactams, for the bactericidal activity. That's why we are giving. So it will reduce the total duration of antimicrobials. Even sometimes 4 weeks duration of ceftriaxone can be reduced up to 2 weeks, because if you use with the combination. Can be used in a single daily dose regime in most indication, because you are aware gentamicin can cause uh, nephrotoxicity. Single daily dose with high peak levels, which is very beneficial for the antibiotic killing, but it is less associated with nephrotoxicity. So rather than giving multiple doses, the renal point of view, giving single daily dose is more beneficial. So just next few slides don't need to buy hard. I just want to show the guideline and what we do, because sometimes it is not ideal. We are slightly deviating from the guideline. For example, for initial empirical treatment, the suggestion is ampicillin is ceftriaxone, no flucloxacillin and gentamicin, but what we give is ceftriaxone plus gentamicin. Then if it is allergy, vancomycin with gentamicin you have to give. If it is if you identified oral streptococci uh, oral streptococci, you have to give penicillin or amoxicillin or ceftriaxone. Or if you want to reduce the duration, as I mentioned earlier, if you give with gentamicin, total duration will reduce to 2 weeks. It's a beneficial. If patient is allergic to beta lactam, it is vancomycin. So, but basically, I know this is decided by your consultant, what is the antibiotic, and with the help of the microbiologist. But you should know some of the basic uh, concepts. So, methicillin resistant staphylococci we are treating with vancomycin. Methicillin susceptible staphylococci are treated with flucloxacillin or cloxacillin. So Brucella and other ones have different regimes. You don't need to remember like doxycycline, Cotrim and other things. Here rifampicin in our country, because some other countries they use in a different name for the same drug. So we are treating with these antibiotics. So some patients need surgery. Why these people need surgery? There are three main indications. One is heart failure. Right? Heart failure, or failure to control infection, or prevention of septic emboli. Those are the three indications. If I go back again, Right. These are the three indications: heart failure, failure to control infection, or prevention of septic emboli. These are the three main indications. So if I refine that, when to refer that, there are three terms. Emergency surgery means in the guidelines say it is performed within 24 hours. Only with few indications for that. And urgent referral means within few days. Elective referral means within 1 to 2 weeks of antibiotic therapy. You know, this is really not practical in our setup most of the time. But according to the guidelines, if the patient has heart failure with cardiogenic shock, with it related to the infective endocarditis process, you need to have emergency surgery within 24 hours. Oh, similar thing happens with in a mild way, you have to have urgent surgery. The second indication is failure to control infection. Then you consider urgent surgery, that means within 1 week. That means then you have aortic root abscess, aneurysm, fistula formation, expand in vegetation size, and difficult to treat organism, persistent of positive blood culture. Likewise, then that's why you need an infective endocarditis team. That means you can't manage this. Then get the surgeons on board and discuss. Now we are not going to treat with our antibiotics, whether we have to remove that part or abscess or whatever, or shall we remove this infective foci or focus. So if the patient is having septic emboli, especially if the patient is having large vegetation more than 10 millimeter with embolic episode, that means patient had some embolic episode, or maybe say example stroke with large vegetation, despite antibiotic therapy, then you consider urgent surgery. Right. So follow up of these patients. So you have to treat these patients according to that particular duration, and at the end of your treatment course you have to do that 2D echo at least, and then your clinical and other parameters should be okay. And the complications usually occur within the first 12 months. So ideally you have to follow up these patients periodically, maybe every 2 months, 3 months. They say 1 to 3, 6, 10, 12, according to these guidelines, because there's a risk of recurrence is 2 to 6%, and maybe 30% patient need surgery. Important thing is patient education regarding good dental hygiene, avoidance of intravenous drug, body fears in tattoos, and you have to importantly give about the prophylactic measures, including antibiotics, which I'm going to tell. So few words about prevention of infective endocarditis. Why? Rationale is the development of infective endocarditis requires there should be a predisposing factor. The surface that could be colonized by the bacteria. And there should be pathogens entering the bloodstream. There should be competence of the host immune system. If there are immunosuppression, there will be more predisposing for the infective endocarditis. So you have to think about the portal of entry as well. So if I summarize this, you have to specially think of population at risk of infective endocarditis. These are the people who has very high risk of infective endocarditis. Patient with previous infective endocarditis, highest risk. Patient with surgical implanted prosthetic valves with TAVI, transcatheter implanted prosthetic valves, or any material used for cardiac valve repair. and many of the congenital heart diseases and patient with ventricular assist devices, especially many of the cyanotic congenital heart diseases. These are the high risk people, right? So intermediate risk are rheumatic heart disease people, non-rheumatic degenerative valve disease, congenital other congenital valve abnormalities including bicuspid aortic valve diseases, cardiovascularly implanted electronic devices like our pacemakers, hypertrophic cardiomyopathy. These are coming in the intermediate category if you are thinking about the heart valves. So we have to educate these high risk people and intermediate risk people about this. I already mentioned some of them because this already we have done for the patient who are discharging. Maintain good dental hygiene. Use dental floss daily. Brush teeth morning and evening. And you have to get regular checkup with your dentist. They say affected people at least 6 monthly should see the uh, dentist, and moderate risk people at least annually. And we have to educate about the good skin hygiene, minimize risk of skin lesions. If there are any lesions, that means if there are any evidence of septic focus like redness, swelling and tender pus, you have to get the immediate treatment with your doctor and avoid tattoos and piercing, and be mindful about infection and do not self prescribe antibiotics. So antimicrobial prophylaxis, so that is the one of the way we can help with high risk patients. Especially it is recommended for previous IE patients. These are the this is the high risk groups we have mentioned here. Most of patients with surgical implanted prosthetic valves and with any material used for surgical cardiac valve repair, and transcatheter implanted aortic and pulmonary valvular prosthesis, and untreated cyanotic congenital heart disease, and patients treated with surgery or transcatheter procedures with postoperative palliative shunts, conduits, or other prostheses. Any of the devices we put, for example, atrial septal device disease, ASD devices, within first 6 months, patient needs this prophylaxis again, or PDA device. And in patients with ventricular assist devices, which needs antibiotic prophylaxis. And also, you can consider, not up to that level, any patients with transcatheter mitral and tricuspid valve repair, and patient with heart transplant. And low risk patients, it is not recommended. So what are the antibiotic regimes? They suggested amoxicillin 2 gram orally, single dose 30 to 6 minutes before the procedure. Or if somebody is allergic to penicillin or ampicillin, you can try with cephalexin, unless it's a very real anaphylactic type allergy. If it is severe allergy, you can try with azithromycin or clarithromycin or doxycycline, because you should not use cephalosporin in the presence of severe penicillin allergy, because they are very closely related groups. Because prophylaxis, if you decide on prophylaxis, you have to think about two ways. One thing is your patient underlying condition, as well as the condition patient is undergoing. So we have been talking about so far we have been talking about the patient's underlying condition. Now we are thinking about what is the procedure he is going to do. So especially dental procedures are high risk, especially which involves the breach of the mucous membrane, like dental extraction and many oral surgeries, and any other surgeries including gingival or periapical region of the teeth. This guideline actually has some changes from the previous guideline from this slide, because previously they say you don't need much on other procedures involved in the respiratory GI or GU tract, for example upper GI endoscopy. But according to this guideline, if your patient is high risk, you can consider prophylaxis if you are going for cardiovascular interventions, skin procedures and wound management, transfusions, dialysis, bone marrow punctures, and endoscopy procedures. Now they are coming back and telling you might give you, it is recommended actually to be C as a prophylactic uh, therapy. Right. What is the prognosis of infective endocarditis? In hospital mortality is around 15 to 20%, and 1 year mortality is around 40%. Left side has infected endocarditis has higher mortality, and Viridan's group and native valve endocarditis has better prognosis. As I mentioned, prosthetic valve endocarditis has worse prognosis. So higher mortality, in other words, uh, the worst prognosis can happen with Staph aureus endocarditis, uh, if the patient has prosthetic valve endocarditis or any main complications like pulmonary edema, that means heart failure, paravalvular involvement, and out of the valves, mitral valve agitations, other comorbidities, old age, and all these things. So, few words about CIED. What are CID? Cardiac implantable electronic devices like permanent pacemakers, ICDs, CRTs, and all. So, infective endocarditis of these devices are increasing because number of devices are increasing. So, they may manifest as percutaneous device erosion or purulent drainage at the pocket site. There may be surrounding erythema. They may be just appearing as pocket infection. If you are working at EP ward, so if you have a EP consultants in your hospital, you might have seen that. It's just like a pocket infection, but it can be a infective endocarditis of CIED. There may be swelling at the pain of the site, swelling and the pain at the site. There may be pulmonary manifestation because these are involved in the right-sided endocarditis, pleuritic pains, pulmonary manifestation, pulmonary infiltrates, and lung abscess, and hemoptysis, and pulmonary infarction, and all these things. In addition, they can have our usual manifestation of cardiac manifestation and other peripheral stigmata of infective endocarditis, which I have been talking. So their cause is most likely Staph aureus in the majority of case. Sometimes streptococcal and enterococci. So again, so usually you do the same thing. You clinically suspect, get the blood cultures, 3 sets. You do the echo, transthoracic echo, but here TOE has a higher place. You have to do the TOE, but sometimes it might not get that and get the PET scan, SPECT scan, or CT scan. It might help and treat with IV antibiotics. And you have to consider complete removal of the device and have some time and reimplantation later. It has to be divided, discussed with the patient and the team when to pre-implant, and there are a lot of complex things has to be discussed in the higher level. So I think I'm actually at the end of my presentation. Yeah. So basically, this is the ESC Clinical Practice Guideline 2023, but Brownwood Heart Disease, Mayo Clinic, and EA textbook of echocardiography, as well as Duke's update and prophylaxis, some other references. Special thank for the Dr. Shirani Tandasiri, microbiologist, and Dr. Chandrika Ponnamperuma, consultant cardiologist. Right.
Version, there is a question in the chat which says, if there is no any active heart disease, is there a place for enoxaparin? Erosion?
Yeah, is there any no active heart disease? Is there any place for enoxaparin? Does that mean in the infective endocarditis, if there are no other indication, enoxaparin is indicated? Is it the probably that is the
Yes.
question, isn't it?
Yes.
There's no indication.
Yes. Yes.
Enoxaparin has no indication.
Okay.
I think, yes, in the absence of,
Sir, so one
the-
more question, sir.
yes, sure.
Can infective endocarditis per se can cause acute coronary syndrome? And if it happens, is there a role of what about the thrombolysis? I don't know with this. I was thinking about hypothetically. I don't know whether there are can happen.
No, I don't think even this guideline clearly say about that. Actually, I can't remember. I can't recollect anything related to that.
Yeah.
Uh, uh, if it happens, there is the two ways. One thing is if it's an embolic phenomenon,
Yeah.
uh, uh, there is a less chance of thrombolysis, isn't it? Because it's not a thrombus.
Yeah. So.
So that's why thrombolytics are not indicated even in the head intracranial. So I don't think it is thrombolysis indication in that case.
So.
But I'm not 100% sure about the thing in the guideline, but they didn't mention about that as far as I am
So
concerned.
do we get cases like that, or I was like it came to just my mind?
So it's possible. You can have
Possible, sir.
a high risk of yes, you can have acute kidney syndrome with this.
Sir. Okay, sir.
But it's slightly high risk, not the very high risk with this. Any infection can precipitate acute coronary syndrome. It's a known phenomenon.
Right. Okay, sir. Thank you.
But the other thing is very difficult to diagnose this. Remember, because you can have troponin rise with the infected endocarditis itself, right?
Yes, sir. I took. Thank you, sir.
Thank you.
It's almost 10:35. So in the absence of further questions, let me thank Dr. Niroshan Lokunarangoda for his excellent coverage and extensive presentation on infective endocarditis. Hope you will join us in the coming years as well, Dr. Niroshan. And thank you very much for that lecture. Thank you.
Thank you very much, sir. Thank you for the audience as well. Thank you. Good night.
Good night.
Thank you, sir.